Hello, everyone, and welcome to today's webinar on PPE Access for All, hosted by the COVID-19 Action Fund for Africa. I'm Gabrielle Fitzgerald, founder and CEO of Panorama and co-founder of the Pandemic Action Network. The network was proud to be a core collaborator with the COVID-19 Action Fund for Africa. Before we get started, I'm going to give you a quick acronym warning. There are three acronyms you're going to hear a lot today. First, we refer to this initiative as CAF-Africa. Second, the community health workers this initiative supported are often referred to as CHWs. And third, an acronym that we've all heard way too much over the past year is PPE, for personal protective equipment. So now back to the topic at hand. CAF-Africa is a radically collaborative partnership made up of more than 30 organizations that came together to support community health workers on the front line of Africa's COVID-19 response. This time last year, it became clear that some of the systemic challenges facing community health workers were jeopardizing their ability to access the most basic personal protective equipment like surgical masks. There was no easily accessible information that indicated how many CHWs needed PPE. Not surprisingly then, global forecasts and most supply chain plans excluded the PPE needs of CHWs. And beyond those challenges that were unique to CHWs, the world's wealthiest countries were scrambling for scarce personal protective equipment and driving up prices. This scarcity meant that initial PPE procurement efforts for sub-Saharan Africa prioritized facilities that were providing treatment for COVID. That meant that roughly 900,000 community health workers, who are the first point of care for so many communities, would be at personal risk. And health services to those they served would slow down or grind to a halt. Early last summer, in the face of this urgent need, a diverse group, including ministries of health staff, experts in supply chain, and groups representing community health workers, came together to create the COVID-19 Action Fund for Africa, a time-bound initiative to get surgical masks, face shields, and gloves to community health workers. Collectively, we conducted a rapid needs assessment, raised money, procured supplies, and ensured last-mile delivery. Just 9 months later, we have delivered more than 66 million pieces of PPE for nearly 500,000 community health workers in 18 African countries. We were able to do this by securing more than $18.5 million in philanthropic contributions and in-kind support. In addition, 15 million non-surgical masks were provided for schools and other local organizations. As someone who speaks regularly about the importance of catalytic coalitions to make change, I'd like to offer a few observations about what made this radically collaborative initiative succeed. First, this has been a coalition of the willing, a bootstrapped effort that moved nimbly in the face of an evolving pandemic to ensure last-mile delivery. Second, we've worked with urgency, making no-regrets decisions quickly to protect as many CHWs as possible. Third, the initiative was designed so that all efforts were endorsed by government leaders who coordinated across multiple departments, including those focused on supply planning, community health, and newly created COVID coordination hubs. And last but not least, every individual and every organization who participated in CAF-Africa put ego and brand aside and focused on achieving the task we collectively set out to achieve. Along the way, we learned many lessons that need to be utilized both as we continue the battle against COVID and also as new policies and systems are created to ensure the world is better prepared for the next pandemic. Our time together today is designed to share those lessons, which we hope will be helpful to all of you participating. You will hear from CAF-Africa's global, regional, and in-country partners about the impact, the journey, and the future of PPE procurement for community health workers in Africa. We have 3 moderators today. Mila Nipam-Nishi, Director with the Community Health Acceleration Partnership, Krishna Jaffa, CEO of Precision Global Health, and Emily Bancroft, President of Village Reach. And now, let me hand things off to Mila to get us started. Thanks for joining us today.
Thank you for that introduction, Gabrielle. And thank you everybody for joining us today. The Community Health Acceleration Partnership provided central coordinating and catalytic funding support for CAF-Africa. It has been our honor to work with such an incredible group of diverse colleagues from around the world. And I would like to take this moment to show you a video that I hope will convey the diversity, the breadth, and the depth of what it took to pull this off.
Rarely are things in global health as clear, but we realized pretty early on that you cannot maintain essential health services, fight the virus, and protect the most vulnerable without supplying CHWs with PPE.
We need protection like other health workers.
Without the protecting devices, I'll put the community members at risk. At the same time, I'll also be putting myself at risk.
However, the community health workers are last in line for the personal protective equipment, the PPE.
To address this challenge, more than 30 organizations in 20 ministries of health came together to scope the PPE needs across 24 African countries.
Our partners around the world work quickly to purchase, verify, and deliver PPE at scale.
We mobilized funds and other in-kind resources,
including advocacy for community health workers to be protected with PPE.
And our partners supported distribution from the factory to last mile.
CAF-Africa partners committed and delivered more than 66 million pieces of PPE to over 500,000 community health workers.
The majority of this equipment was delivered to countries with support from the World Food Programme, which generously provided free cargo flights throughout the pandemic.
We, the CHWs, are the frontiers in COVID-19.
And when we are not going to meet with our clients because we don't have PPE, we are going to put the community in the risk.
As community health workers await the vaccine, they still require PPE.
PPE remains essential to protect community health workers and the communities they serve.
Protecting community health workers now is essential to ensure they are equipped, paid, and supervised into the future.
And we must work together.
We must all work together.
We must work together.
We must work together.
We must work together to secure PPE for all.
Good morning, good afternoon, good evening to all our participants. We're delighted that you are with us today. My name is Dr. Krishna Jaffa, and I'm the CEO of Precision Global Health. And it's my privilege to kick off the discussions that you're going to hear today, which will be in 3 parts. The very first part of our webinar today is going to focus on the impact of both COVID-19 as well as the positive impact of receiving PPE that then protected CHWs. So I would like to introduce the first panel, who is going to speak about the impact of both the pandemic as well as of PPE from the perspective of 3 very different country contexts. I'm delighted to introduce James Lipenga, who is a community health worker supervisor in the southwestern part of Malawi that also shares an extensive international border with Mozambique, neighboring Malawi. And he will share with us both some of the challenges as well as some of the opportunities that are now created when community health workers are protected. Next, we'll hear from Freddie Nkosi, who is Village Reach's country director in the Democratic Republic of the Congo. And last but not least, in hearing about the impact, you're going to hear from Dr. Maureen, who is the National ICCM Coordinator for the Ministry of Health in Uganda. So with that, really excited to get this first conversation started. And we're going to kick off with James. James, you are a community health worker supervisor in a fairly remote part of Malawi, 6 hours from Lilongwe, as I understand it, the national capital. And you also have a pretty extensive international border, as I mentioned, with Mozambique. Can you share with us what the experience of COVID-19 has been like, both from when it first started affecting your work and impacted your community up until the present, when vaccines are beginning to be rolled out? Thank you.
Thank you so much, Krishna, for having me. My name is James Lpenga, CHW from Malawi. My roles include screening children from malnutrition, vaccinating children, supervising water and sanitation activities, screening for TB at the community level. During this first wave of COVID-19, the government expected us to continue doing our work and add on the role screening for COVID-19 suspected cases to the rapid response team that exists at the district health office. We were afraid because of this COVID-19 because we did not have PPEs. The government revised some of our workflows. For example, we stopped collecting sputum from the community, screening children for malnutrition using MUAC, main upper arm circumference. However, in the course of our work, we received consignment from CAF-Africa and again from partners in health. We were able, and again, we were excited with the consignment in such a way that it paves way from our fear. Since we did not have these PPEs, then we were able at least to resume to our previous work. For example, like screening, go ahead with the screening. So those are some of the activities that are done during this. Right now, I just want to talk on the situation that is here in Malawi. Last 24 hours, we got few cases, meaning to say COVID is going down in Malawi. We have got few cases that has been recorded in 24 hours. And finally, good news to say that as a CHW, I got a single jab vaccination of COVID-19 last week. Thank you, Krishna.
That's so wonderful to hear, James. And thank you so much for sharing the story, which I think really brings alive for our audience. Many of us are not on the front lines. We're not in countries where there are resource constraints. I think it really brings alive for us the experience that you had. And because we've all been reminded so many times of the timeline of the COVID-19 pandemic, could you briefly share with us when you started providing COVID-19 related services in 2020?
We actually started this 2020 in February.
Wow.
2020. Yeah, it's where we started that.
It was very early in the pandemic. And when did you receive PPE for the first time?
It was in April 2020. It's when we received that consignment.
Okay, that's yeah, really interesting. So it took a couple of months to get the PPE to you. Yeah, I think a really great reminder again of the importance of protecting our frontline workers. And thank you again, James, for sharing that story. We're going to switch geographies a little bit more. So Dr. Maureen, I'd like to reintroduce you. as the National ICCM Coordinator for the Ministry of Health in Uganda, you have been a champion for community health workers throughout your career, and that has become even more evident when the COVID-19 pandemic hit, and you've provided so much leadership and inspiration to the CAF-Africa team in helping us support your work. I know that you've had a lot of challenges, and I know that you've been able to address so many of them. So if you can share the story from Uganda in terms of, this leadership position that you have, the bird's eye view you have across Uganda, what were some of the challenges and what are some of the opportunities and gaps that remain? With that, over to Dr. Maureen, and if you can just unmute yourself, that would be great. Thank you.
Thank you very much, Krishna, for the introduction, and thank you all for being a part of this. Well, at the start of the COVID-19 pandemic in March, we well know that the whole world was hit and Uganda as well was not spared. And we had efforts across the country to protect the health workers with personal protective equipment. But these were, however, prioritized to the health facility workers and not the volunteers, community health workers, as we call them in our country, the VHTs. VHTs being a voluntary health cadre, they were not required to work under these circumstances. However, we very well know that the VHTs are the first point of care, of contact in the communities, and provide basic health services and education to over about 84% of the Ugandans living in the rural areas. And it's therefore essential that we consider PPE for these people. However, as we moved further to the current phase 4, which is the community transmission stage of the pandemic, the need for the VHTs was critically crucial and important for them to be a part of this, especially for surveillance, for home-based care, for community engagement. And we very well know that COVID-19 has similar symptomatology with malaria and pneumonia, which are the cases that are handled at the community level by the VHTs that are offering case management, especially for the integrated community case management of childhood illnesses. So there was really a need, and facilities were closed across the country, and we had most services that are shifting to the community. And therefore, it was imperative that really we have the VHTs work, because this was already an additional burden to them. We've had quite a number of PPE donations coming into the country, but these have been piecemeal from different agencies. But CAF-Africa sent the largest quantity to protect over about 80,000 VHTs across the country. And this has had several positive impacts in ensuring continuity of essential services at the community level, like for malaria, pneumonia, diarrhea, exposure to TB, among others. And this has also maintained the trust and confidence among the VHTs, but also strengthened our collaboration between the private and the public sector for services. We provided this PPE across both the public and the private sector, and therefore the collaboration was strengthened, and we had reduction in severity of cases because the cases were seen by the VHTs within the first 24 hours. And to date, we thank our partnership and advocacy for the VHTs, which is increasingly getting onto the agenda. The VHTs were able to receive the PPE, those are the face masks, eye goggles, to enable standard operating procedures and support for continuity of essential services. But we also modified the guidelines for implementing the ICCM within the COVID, trained the VHTs on the standard operating procedures for COVID-19 prevention, and also the president endorsed the new community engagement strategy for COVID-19, where the community health workers, the VHTs, will be paid a particular salary by government. This may not run across the country, but it's a step for us in the right direction. The PPE quantifications have also been included in other grants, like the Global Fund grant, especially for ICCM. We, however, remain with a few gaps where there is need for advocacy for the vaccine of the VHTs as they continue to remain last in line. We know that the phase 1 of our vaccine within the country was mainly for the health workers, the teachers, and the force. And we hope that within the phase 2, at least with our advocacy, we will be able to also have this vaccine for the VHTs since they are frontline health workers. There's also a continued need to rally to support the VHTs at all fronts. and remunerate them, as well as make sure that they're able to provide these services. We know that PPE is still essential even during this period of COVID, and therefore we continue to advocate and ensure that we have enough PPE for the VHTs as they continue to do their work. Thank you.
Thank you so much, Dr. Maureen, for sharing with us both what some of the struggles were as well as what some of the opportunities are. And just very quickly, what's the timeline for rolling out COVID-19 vaccine, and are CHWs currently included in the quantification and in the rollout plans, or is that still to be done?
Well, within the first phase started within March, and it ends around April, and we'll have a second batch coming in May. The first batch does not have the community health workers apart from those that are elderly, but the second phase, yes, we have advocated for inclusion of the VHTs within the second phase of the vaccination within the country.
Thank you so much. And with that, from Dr. Maureen in Uganda, we're going to switch to Freddie in the DRC, and hopefully at least his audio will work at this point. So Freddie, without any further delay, over to you.
Yeah, thank you very much, Krishna. I'm very excited to share the experience of the Democratic Republic of Congo in the distribution of PPEs to reach some of the community health workers, especially those living in the rural areas. And we were able to achieve greatest results because of a strong partnership between the Ministry of Health, Village Reach, but also other technical partners, even other donors who came together to support this distribution. When I hear James' story about how community health workers were not prioritized in Malawi, this also relates the same story in the DRC. At the beginning of the pandemics in March last year, community health workers were not a priority to receive PPEs, as there were very limited quantity of PPEs, but high demand. So the priority was given to frontline health workers or those who are working mainly or treating COVID patients. So with the collaboration with CAF-Africa, we were able to receive over 5 million of PPEs in the DRC. And so far, we have reached over 17,000 community health workers receiving the PPEs, and mainly those are living in the rural areas. And for most of them, that was the very first time since the pandemic started to receive the PPEs. And if you hear their stories, how they were feeling exposed without having the PPEs before they received the consignment that we had from a CAF-Africa, it's amazing. Like, it's a life-changing for them, and mainly also their profession, they were feeling more comfortable, more confident, and to continue doing their work while they know they can protect themselves. But also, we were able to distribute over 7,000 face shields to support the polio campaign that was in October last year. And from the following slide, you're going to see the picture of community health workers during the polio campaign. And that was the only PPEs that was available for them to support the polio campaign. That's the picture on your left side. But also the particularity in DRC, we were able in some provinces, such as in Equatorial province, where we are already using the drone to integrate the PPE in the distribution of other commodities where we use the drone. So we were able to use the drones to transport masks, medical gowns, face shield, to reach some of the hardest places to reach in Equateur province. So for DRC, it was a great collaboration between the ministry and village reach, and we use what we are best to do in the country, the direct distribution, but also integrated distribution, meaning integrating the PPEs in the distribution of vaccines, in the distribution of other essential medicines. And we had a great success and great impact, great success stories coming from the community health workers who benefited from those PPEs. Maybe I can stop there. Thank you.
Yeah, thanks, Freddie, for sharing that. And just a very quick follow-up question. We know that it's very, very expensive to do air freight, especially for such bulky items. And you had mentioned that that was a constraint. How did the DRC go about addressing the constraint of the costs of air freight, and what got mobilized internally versus coming from outside the country?
Yeah, the biggest challenge in a country such as DRC, with the size of Western Europe, with very poor road infrastructures and a lot of geographical challenges, it is not easy to move products from the central warehouse in Kinshasa, which is the capital city of DRC, to the rest of the country. So that was the main challenge. And we have seen some provinces such as Haute-Uele province, where the governor of that province mobilized domestic resources over 50,000 US dollar to transport PPEs from the central warehouse in Kinshasa to that province, which is over 2,000 miles away from Kinshasa. And not only mobilizing the resources to transport the PPE to the province, but also ensuring the last mile distribution. It was a buy-in from the local authorities and from the onset.
Thank you so much, Freddie. So with that, we have reached the end of the first part of our webinar, in which we talked about the impact of both the pandemic as well as the impact of receiving PPE and allowing community health workers to resume what in some instances were severely disrupted activities, while these CHWs were actually expected to not only stream in to do more community-based care for COVID-19 with all the risks that that brings, but also to be continuing with their routine healthcare service provision. So you heard from James about how that was disrupted early in the pandemic, where CHWs could not accompany sick patients to facilities because they did not have sufficient PPE, and how that changed when they received PPE from partners in health as well as from CAF-Africa. And then you heard from Dr. Maureen about sort of, both from a policy standpoint and the country leadership, the importance of having policies and SOPs and standard operating procedures in place, as well as actually making sure that there is continuity. Several messages that we hear about fragmentation of funding, fragmentation of quantification, and the need to continue paying attention to that. And then last, we heard from Freddie, not just about how a massive country with many internal logistical challenges was able to respond, but also about some of the innovative approaches that they used, including drones. So thank you again to James, to Freddie, and to Dr. Maureen. And we're now going to start the second part of our webinar. And you're going to hear a little bit more about the journey that PPE takes from where it is manufactured to where it actually gets used. And even before that journey starts, you need to start with advocacy. You need to start with very clear messages regarding policy and advocacy and funding. This is an exciting topic, and we've got three wonderful speakers. Again, I'm delighted to introduce Dr. Madeline Ballard, who is the Executive Director of the Community Health Impact Coalition, Andrew McCalla, who is Vice President, Emergency Response and New Initiatives at Direct Relief, and last but not least, Tapiwa, whom many of you know, who is the Director of Supply Chain at Village Reach. Madeleine's going to speak briefly about the role that SHIC has played, Community Health Impact Coalition has played, and the voice that she has provided along with others to prioritizing the needs of community health workers and to protect them. Andrew's then going to take us through the journey from factories to getting the PPE in country, and then finally Tabib was going to talk about being the connective tissue, he and his team about being the connective tissue between the supplies coming into national capitals and then all of the efforts it takes to actually get them to the last mile and all the challenges that are faced within that. So with that, we're going to start with Madeleine. And Madeleine, you were one of the earliest voices to highlight the importance of protecting community health workers in the context of COVID-19 so that they could both continue to provide essential health services as well as protect themselves, which is, of course, incredibly important from an ethical standpoint. So we'd love to hear from you what key messages you emphasized at the start of the pandemic and how that journey has been, what messages got listened to, which ones didn't. So over to you.
Sure, thanks so much, Krishna. So just to briefly recap, because Gabrielle gave such a great overview of the situation as it was last March and continues to be in many ways today. And then James added that color sort of from the front lines of providing care. Basically, what we realized, and I should say I'm speaking on behalf not of myself, but of the Community Health Impact Coalition, which is a team of practitioners working in over 40 countries who've come together to make professionalized community health workers a norm worldwide, which is to say paid, adequately equipped, adequately supplied, because too often that's not the case. So what we quickly realized at the beginning of the pandemic was that we were facing this triple burden. There was an absolute shortage of PPE in the world. There was a large geographic and intra-cadre disparities in that, as was mentioned, a lot of low and middle income countries were not getting quite the access that high income countries were, to put it politely. And then even when PPE did make its way to many of these countries, CHWs were last in line. And I think this reflects existing ideas about their worth as healthcare providers, which again are not borne out by the evidence. We know that community health workers are essential to providing and maintaining key health services, everything from malaria testing to vaccination to malnutrition case management with mock tapes, like Freddie mentioned. And then again, we're taking on these new roles in COVID-19, case finding, in Kenya, home-based care provision for COVID patients. And it's really worth re-emphasizing, as James did, that none of these services can be done over the phone from 6 feet away or with only a homemade mask. And in the absence of PPE, as was explained, these services were stopped. Or we saw community health workers being asked to work without protection, which again puts themselves at risk, puts their families at risk, and basically presents the situation where, as they go house to house to house, they can become virus transmitters rather than agents of healing, which is, ultimately what they can become, but only if they're well supported. So you saw in the video, this is what I shared. It's so simple. Again, I think there are so few silver bullet, quote unquote, interventions within the global health space. This comes pretty close. Without PPE, CHWs cannot maintain essential services, which again often kill more people, the disruption of which often kill more people in pandemics than the pandemic itself. They can't take on these additional roles for COVID. They cannot protect the most vulnerable. And so the first thing we did is, in collaboration with CHAP and the Center for Global Development, we quantified the problem. We tried to validate the annual PPE needs to protect an estimated 900K CHWs in more than 20 countries across the continent, which and that represents about 40% of the population of Africa. What would it take to protect them? And we estimated that these CHWs would need approximately 440 million pieces of PPE to protect themselves and their communities while maintaining this essential services over the course of the year. And this is really critical because we didn't just kind of go and do this off in the lab. Because we had this network of health practitioners working in so many countries with ministries of health, they were able to work together with us to quickly validate those estimates, because they knew that as soon as these counts, again, long overdue, were done, they would immediately be put to work in requisition forms to secure the donated PPE. And this might sound strange to folks, like why don't we know how many CHWs there are in countries? But I think this is one of the inequities that COVID has highlighted, that again, because so often these health workers are treated as sort of informal cadres, suddenly when it comes time to needing to protect them and engage them, we don't know who they are, where they are, or how many there are. And so that was definitely step one. And it allows us to make these key recommendations. One, that countries need to use these numbers to make sure that CHWs were included in national PPE supply chain plans, not just for this requisition through CAF-Africa, but moving forward, other sources. Again, I think CAF-Africa was one of the 5 largest procurers of PPE in 2020, but 400 million, and that's just for CHWs. You need a lot of actors in this space, and there were other actors. And so we were trying to change how all of that was done. That we deploy PPE for CHWs alongside pay, training, supportive supervision, all the things that they need to reduce stigma, and that we investigate opportunities for domestic and regional manufacturing, which I think you'll hear more about from our other partners. So those were some of the key things that came out of that early part of the pandemic.
Thanks so much, Madeline, for taking us through that part of the journey. And it's really interesting that this is a journey that we seem to take as the global public health and supply chain community over and over and over again. I think one of the potential positive outcomes of a global pandemic of this size and scope is that it really has gotten the attention of the entire planet. It is tragic that it took so much to focus in on frontline workers, community health workers in particular. But just looking at, you touched on a few points. Only 14% of community health workers, I understand, are actually salaried. The vast majority of them are volunteers and receive intermittent stipends. So that's a really important point as well. And we need to stop making excuses, is what I'm hearing. And we now have estimates, we now have evidence, we now know what is taken. And I think what was really striking to me was that that what is needed to from the quantification exercise that you and others did with the Center for Global Development, my understanding is what's needed to cover most African CHWs is $100 million of PPE a year. And I think that really sticks with me, and I hope it'll stick with the audience and spur us to action to make sure that this is the last time we need to discuss things like this, and actually be better prepared the next time. So with that, I'm going to transition to Andrew McCullough, who is leading direct relief's efforts for purchasing as well as procurement, and he's going to walk us through this really exciting journey of massive supply chain procurement in record time. As a supply chain practitioner, I was blown away by how quickly you mobilized, how rapidly you were able to get commodities in country and start to distribute. So over to you to share that part of the story of the journey. Thank you.
Thanks, Krishna. And I think, what was so great, just to start with, about this partnership was that this massive partnership was that it leveraged everyone's strengths quite well, as you said. So, direct relief supports CHWs all over the world, including in the US. We know they're always the last in line for supply, but we've supported CHWs in Africa for many years, but there's no way that we would have had the ability to do the quantification work that Madeline and the team described. So once we had those numbers, we could go and do what direct relief does best, which is sourcing the commodities that are needed at the highest quality and get them to partners at the lowest cost. But as everyone might remember, back in April of last year, a year ago, there was a global shortage of PPE. Everyone in the world needed the exact same thing at the exact same time. Countries were bidding against each other, like cities and states were bidding against each other. I live in Los Angeles. I remember the mayor of Los Angeles was bidding against the governor of California. So it was really hard to get the supplies you needed. Prices were going up. That led to bad actors in the system, counterfeit products. Defense Production Act was enacted so that U.S. suppliers, we couldn't buy from U.S. suppliers for export. Indian and European manufacturers weren't exporting anything. So the supply challenge was very real. So we started a pretty rigorous procurement effort to overcome these challenges. And it's not something we actually do. Direct Relief donates about $2.8 billion worth of medicine every year. Most of that is donated. So we aren't actually typically a big buyer. But what we had was, we had these very real numbers, a very real need. We had the availability of cash. And because we were able to pool this large, extremely large need, we were able to find relationships, develop relationships directly with manufacturers, mostly in China at this time, who would actually take our order because we had cash on hand and a large need. And then we had a team that could vet those supplies in China before we needed to ship them. We didn't go through brokers. And we were able to then also bring the cost down from then till now by about 60% from what the prices started out at. So in the end, we were able to procure about the equivalent of 89 747s worth of supply, about almost 3,000 pallets from about 7 different countries, about 500 tons of product supplies in total. A lot of those numbers don't mean much to anyone. 500 tons is the equivalent of 3 statues of Liberty as a way to think about what that is. But then we needed to get that all to these 18 countries in Africa. And that was not only a huge logistical challenge, but it was a very high cost associated with that. We wanted to get it there fast, so we didn't want to use ocean freight containers. We wanted to fly it, and that's where the World Food Program came in. It truly saved the day. We're offering a free-to-user service for PPE. We became their 3rd largest user of that service globally, out of 70 organizations, just after UNICEF and the WHO. And they transported it all for free, saving us, the initiative, millions of dollars, which we could then put into more supplies for community health workers. And I can't say enough about how incredible that was and that offering. And then the last thing I would say is we were always looking to see, can we get any of this locally? Can we support local manufacturing in these countries? Always had an eye on that. We were able to, by the end, early 2021, able to make purchases directly in Kenya and Ethiopia from local suppliers, manufacturers, to support those local efforts, as well as reduce transport costs after WFP stopped those services. So I think I will stop there.
Thank you, Andrew. Just one last thing before we switch to Tapiwa and hear about sort of, how then the PPE got distributed in country. Can you share maybe just as an approximate percentage, because we do want to respect any confidentiality agreements with manufacturers, what the impact of pool procurement was in saving resources and allowing you to then buy even more PPE?
Yeah, for the commodities we purchased, we were able to, with the pooled and the volume, we were able to bring the face shields down by about 30% and the face masks down by about 60% in the end.
Wow, that's really impressive. And I know that as both of you have been talking, we've been getting a lot of requests in the chat for the figures that Madeline and I mentioned. This is actually collaboration with Prashant Yadav and others at the Center for Global Development. You'll hear from Prashant in a bit, and we will send that out to participants as a follow-up. So thank you so much, Andrew, for sharing and bringing that alive. Was it 89 jumbo jets? Wow. And so Tapiwa, you received these 89 jumbo jets worth of commodities, and you're helping countries plan to then distribute them with over 30 organizations, many of whom are on the call today, on this webinar today. And can you describe what that was like and what challenges you faced, what wins you had, and what gaps remain?
Thanks, Krishna. I want to start by recognizing that even though this was an emergency, our logistic goal was to ensure an uninterrupted flow of PPE from the points of origin, which Andrew has mentioned was in China, in Malaysia, all over the world, into the hands of community health workers. We didn't deliver commodities to the airports and considered ourselves delivered. No, we considered ourselves to have delivered once we got the PPE into the hands of the community health workers. And this whole process started with us, like Madeline pointed out, quantifying the needs, determining what the gap was, and this informed the orders that we were able to place with direct relief for the commodities to be delivered to particular countries. This process, I'm happy to say, resulted in us creating some global goods, some tools that are reusable in this emergency and into future emergencies. We have a quantification tool which is available on the Village side, on the CAF-Africa website. We have a gap analysis tool. Look, the gap analysis tool is important to us because we wanted to ensure that we were not duplicative to what other partners, Andrew mentioned that WHO, UNICEF, Global Fund, were also procuring PPE, and we did not want to duplicate that. So we developed a tool that allows us to pick out what the gap was, and we delivered this gap. So this initiative was really additive in that regard. Delivering PPE to 18 countries in an environment in which we have airport closures, flight cancellations, is a very daunting task. It's extremely difficult. But it is even more difficult to deliver PPE in extremely hard to reach areas. No roads, sometimes we had to use canoe, and we had to deliver PPE to close to 500,000 service delivery points who are our community health workers. The constraints were many. We have constraints at the airport, customs clearance. In some countries, the procedures were changing as they were equipping themselves for the emergency response. Look, in Angola, for instance, it took, once the items arrived at the airport, it took over 60 days to get the commodities out of the airport because of customs clearance, red tape, and bureaucracy. And we had to manage that. The PPE is extremely bulky. The storage requirements are for routine environments. And so we overwhelmed the redundancy that systems have. We had to leverage on other sources of storage space. The transportation capacity, it can only be designed to cater for a certain volume of commodities. And again, PPE is bulky, 7 jumbo jets to 18 countries. Some is a very huge consignment to receive. Given that this was an emergency, of course, it costs more to deliver commodities to the last mile, and a lot of our countries that we supported had constraints in the last mile delivery budgets. And so we had to think creatively about how we could cross that bottleneck. But to overcome these bottlenecks, we optimized on synergies with government, with the private sector, with the NGOs and other stakeholders operating in the countries. And I want to say the key success factors that saw us overcome these constraints were, we had the Ministry of Health being at the center and at the front of the initiative. This allowed us to receive customs waivers, duty-free certificates to be able to bring in the PPE, which Direct Relief was able to source at low cost and ensured that it even arrived at an even lower cost because we did not pay customs duty for these. Because this initiative involved 18 governments, over 30 community health organizations, and many supporters, we had to develop MOUs that helped us assign roles and responsibilities, ensure that there was accountability, and it was clear the role that each of the stakeholders was to play in this. Another key success factor was that we understood that there was a surge in logisticians, there was a surge in the number of people that were involved in the logistic process, and we had to deploy rapid training, focusing on commodity handling, pre-planning for receiving, pre-planning for storage and transportation, last mile distribution, and of course, being accountable for the supplies that were being delivered. And we also recognized that even though this was an emergency, sometimes in an emergency, you focus on implementing things on a no regrets basis. But like Dr. Morini has indicated, on the supply chain, we've seen some system strengthening benefits coming out of how we implemented this initiative. For instance, there have been policy changes. We are beginning to see the needs for community health workers being included in the national forecasts. And this is going to happen in perpetuity. This is going to continue. It has resulted in us understanding and knowing the full need for community health workers. So, Krishna, I'm happy that through this, we have been able to drive and influence change in how supplies are planned for community health workers.
Thank you so much, Shabiba. What a great note to end on. So just to summarize, hearing from Madeline, Andrew, and Tapiwa, I think we heard the importance of quantification tools. They exist, so we should be using them. We have working estimates of what it costs to provide protection to community health workers who are providing, as I understand, essential health services to about 40% of the population in the 24 countries that the CAF-Africa team originally scoped out. So that's a large part of health coverage. In terms of being able to rapidly mobilize, working with direct relief, existing relationships, having cash on hand, and pool procurement were critical success factors. And it was really remarkable to see how critically important the World Food Programme's support was in making it all happen. We know that there were many other players behind the scenes in the WFP free-to-user service, but we all recognize how important that was. We've heard some really important constraints from a supply chain and logistics standpoint, but I do want to underscore as we transition to the future that there are also some important systems level constraints that do need to be addressed in a serious manner. These include for community health workers, protecting them in future. It shouldn't be an option, it is necessary. Professionalization pathways that I know the CHW community has long been advocating for, and remunerating them fairly. As I do a lot of work in gender and health as well, and just wanted to also add that about 70% of frontline workers across the globe are women. I think it also becomes a really important gender equality issue for us to grapple with and to actually do something about. So with that, I am delighted to pass the baton to Emily Bancroft, who's the CEO of Village Reach, and she is going to introduce your panelists to talk about the future. Thank you very much.
Great. Thank you so much, Krishna, and everyone that's spoken so far. Working with this CAF-Africa team, both at the regional and the country level over the last 9 months, 10 months, has been such an honor and a pleasure. So it was great to hear all those voices and to hear so many of the partners that have been involved. As you've heard, this really has been a true collaboration. 18 ministries of health, over 30 partners coming together. And so just a really, really amazing thing to be a part of. But there's another part of this collaboration for us, and that is how do we make sure that this effort, which was really intended to be, as you've heard, sort of an emergency stopgap effort, how are we linking into other global, regional, and country level efforts that are also trying to address this problem in order to reduce duplication efforts and in order to be more aligned and to look at how we support this in the future? So I'd like to now, I have the honor of facilitating a panel that's really going to be looking at some of these other experts, some of these other efforts that have happened in the community and in globally, regionally, and at the country level over the last year, so that you can hear a bit more about what else is happening and how we can leverage some of these efforts to solve these problems long term. So I'm joined by three incredible experts in global, regional, and country level supply chains, infection prevention, procurement, financing. So a really, really great panel joining us today. We have Prashant Yadav, who's a senior fellow at the Center for Global Development, an affiliate professor at INSEAD, and a lecturer at Harvard Medical School. And many of you know him as one of the key experts on supply chains and procurement in the healthcare space. We have David Lawrence, who's a senior advisor at the Global Fund, really focused on health security, technical advice, and partnerships. And we have Chitima Ppe, who's the managing director of the Africa Medical Supplies Portal, which is a really important effort of the African Union that also spun up during this time, and has been another contributor to addressing some of the long-term supply needs for countries in Africa. So thank you to all three of you for joining today. I'm going to start with Prashant. And Prashant, you may have seen in the chat already, there's quite a bit of interest in a number of issues around procurement that I'm hoping you can touch on. So our previous panelists talked about some of the real challenges that we faced during procurement in a pandemic. Some of those things, relationships with vendors, pooled procurement and finance demand, global versus local procurement, all these things have sort of come up as themes in the discussion so far. And so you've really been looking at the PPE market, both how it was utilized during the pandemic, as well as what some of the future trends are. So can you share a little bit about what you've learned and also what you see happening in the future? Oh, and Prashant, you're on mute, sorry. Gotcha.
Thanks, Emily. And I want to start by congratulating all of the colleagues involved in the CAF-Africa work. I just heard the figures from Andrew, and it is mind-blowing that you all have been able to do both such a large volume, but also to get it to places which are oftentimes the hardest to deliver to in the supply chain. So commendable effort. I want to start by saying that when we think about procurement architecture for PPE, and there are relationships to many other health products, we should start from the standpoint of the end user and figure out, and the end user here could be the community health worker, or we can then slowly start aggregating and asking where do they obtain their supplies, what would be the vantage point of where they get their supplies from, etc. And then we quickly realize that we want to think about pool procurement, we want to think about regional, global, national pools, but at the same time, we want to give them choice. And when I say choice, I'm referring to a future state of the world in which groups want to say, I want to get my PPE supplies from whosoever can give me the best lead time. Someone else says, I want to get my PPE from whosoever can give me the lowest price. And there are trade-offs intrinsic in this, but in the times of an emergency, the group that knows how to solve the trade-off is the country, is a coalition which is acting on behalf of a certain group or a certain stakeholder group, in this case, community health workers. And so I think that's the starting point for thinking about procurement architecture, which is in the times of emergency, people will have slightly varying preferences for what they care the most about, and rightfully so. Sometimes people may be willing to give a slight price premium in order to get very rapid response delivery lead times. Then I think if we look at the upstream side of the market, we know that it was a market which was heavily supply constrained. Lots of question marks about how do you ensure quality in a market which is very fragmented on the supply side. hundreds, oftentimes thousands of suppliers for certain categories of PPE. And the number and the fragmentation of the market continues to be higher when you go to categories of PPE such as gowns or face masks. It's a little bit more concentrated when you look at respirators and other forms of PPE. So I think in buying from such a fragmented market where quality is not very clear and it's hard to establish, even with enough time and resources being put into ascertaining quality. And on the other side, you have end users of PPE who want some choice, and then finding the mix that balances these two somewhat at tension aspects is what matters the most. And I think the interesting part, what we've seen is that if you look at the data that has come out from the ex post analyses of the procurement work for COVID supplies, including PPE, we realized that about 30–40% was through the WHO coordinated sell, but then there were private market purchases of PPE where countries were buying directly. There were other aggregators like CAF-Africa, and then there were people buying from UN agencies. So I think all of those channels were working. And I think that's perhaps the way we will see the future state as well. We were not always perfect in exchanging information, but I think that's another area where coordination and information sharing hopefully will get better as we think about the new work on preparedness and architecture for preparedness and procurement. But I think one additional item that stands out is that forecasting, and I think it was referred to in the past, is an important signal to the market to get ready for the future, right? So if we ignore some segments, if we completely ignore millions of community health workers in the forecast that we come up with, the market, which is now responding to build additional capacity to ensure that we have not just finished product PPE, but the polypropylene fiber, or perhaps even backstage manufacturing setups, the risk of ignoring this big segment can be a big risk for the future. So I think I'm glad that we've been able to at least put out some ideas in terms of here is the total demand. I think it's an important activity that perhaps we can keep updating. And I think embedded within this is the idea that community health workers, which are not as directly plugged into the formal health system in many countries, their demand or the forecast of what their needs are isn't necessarily aggregating or trickling back up into the national level procurement forecast we are seeing. So as a result, we have this group whose demand isn't naturally coming to the larger procurement efforts, whether it is regional ones or global ones. And we need to think very carefully about how will we bring them back and plug them into a global architecture. And again, repeating myself here, but the global architecture doesn't mean it'll be a single procurement entity that buys PPE for everybody together.
Yeah, no, Prashant, I think you've made so many really, really key points there. And I want to come back to you in a minute after we hear from the others to talk a little bit about local procurement as well and what you're seeing in that market. But let me build on something that you talked about, which is choice. And really the starting point of the procurement architecture being at the country level. And I think that's a place where our other two panelists are really engaged. So Chidima, I want to turn it over to you. The African Union's Africa Medical Supplies platform launched in the midst of this pandemic. It launched in June of 2020. And you've been involved since pre-launch and during this whole thing. And so, I think part of what this portal spun up to do was to help with some of this choice and some of these options for countries and for African Union member states. So can you talk a little bit about, the problem you all were addressing, how that ties to some of these themes that we've heard today, and sort of what then is the future, and what are some of the things you're really excited about around what the African Medical Supplies Portal has been able to do?
Thanks so much, Emily. So the African Medical Supplies Platform, like you rightly said, it came about right in the middle of the pandemic. And the AMSP, it's really a digital marketplace that also serves as a pool procurement mechanism for the continent. So what you quickly realized, when we were in the middle of the pandemic, where there were two levers we could pull as a continent. One, leverage the collective volumes that we have to negotiate downwards some of the prices. Two, provide manufacturers with a very strong financial entity that will guarantee their payments. Because a lot of times you see that some of the manufacturers also kind of shy away because historically they know, Africa, they don't usually will procure this large amount of products at a go. So the AMSP started, from these two levels. And it's interesting that since we started, we've been able to, form very strong partnerships with a lot of the manufacturers that are supplying some of this critical medical supplies and equipment. But I think what's most interesting for us is when we started the platform, I think we had in the first few months, we had something around 100, just a little over 100 million in orders in gross orders for PPEs. So the demand around PPEs, it was really strong, just around that June, July, August period. So that kind of demand was also one of the key, categories that had been requested for by the African CDC. Strong, huge demand, so much complaints around the quality, that they were seeing locally. So they wanted to kind of leverage some of the pre-qualified WHO merchants or manufacturers that we could access through our own network. So AMSP, if I could just summarize, what some of the challenges we really wanted to address. We wanted to make sure on the continent there was proper availability of some of these critical medical supplies. We were all working in a supply constrained market. So it was literally fighting for any bit of products that we could get. And what was also critical for us is to ensure that we got immediate access, right? So, what we had seen when we went into the market was there was some sort of, invisible scale of preference. People that came in later into the market had to wait a longer period to access some of the products. One other thing that was one other challenge we wanted to answer or to provide a solution for was around the cost and transparency. One thing that we were a bit overwhelmed with when we got into the market was just the very wide assortment and wide range of prices. We could see masks that go for as high as $7, $10. Because of the arbitrage that was created, there was a lot of price gouging. Some people were getting them from the manufacturers at really, really low prices. And just because of how scarce it was, the prices were pretty high. So we wanted to really address fully that conversation around cost and transparency. And I think this point is really, really important for us because we were working with a varied group of countries. We had countries with really large population sizes that had the capacity and the capabilities to order huge quantities of products at a time. But we also had countries with smaller population sizes that wanted to buy, just what they needed, especially because they were all working from a very constrained federal reserves. Yeah. Not everybody was getting, donor funds. So the AMSP kind of addressed some of these challenges I've just mentioned. And as we go on, I'm just going to talk a little bit about how we've also evolved as a platform and how we are supporting the communities. Thank you.
Let's come back to that, because again, I think also a great point. And I just want to reference this stat that Prashant mentioned as well, which is that 30 to 40% of country demand was met by, sort of this big pooled procurement effort, very, very important effort that the WHO did. But that leaves, 60% of demand that was met through other channels. And so I think we can't stress enough that, there is a need for multiple channels and multiple platforms. There is also a need for countries to be able to pool their demand. That's something we benefited from in CAF-Africa, being able to pool that demand. And it's something, Chidima, that you're talking about a lot of the member states of the African Union needing to be able to do because of the way that their financing works. So I think just a really incredibly important component. So David, the Global Fund has been one of the leaders, when you think about the global partners and sort of who's taken the lead on PPE access issues, and both sort of shaping how PPE was accessed during the pandemic with the resources that were available, as well as looking forward at what does sort of innovation in PPE look like, what does the PPE market look like moving forward. The Global Fund has been right there front and center through a lot of this, and has also been really front and center in community health as a really critical component of country level response, not just to COVID-19, but to the disease priority areas that the Global Fund focuses on. And you are in the midst of launching some pretty incredible new resources that countries can access through the COVID-19 response mechanism that the Global Fund has just put out new guidance on yesterday, I believe, or even yesterday. And so love to hear you talk about how can countries use that to actually meet their future needs.
Thanks very much, Emily. And let me offer a quick appreciation for the invitation to the Global Fund to participate in this really exciting panel and session. So as you say, Global has been a strong advocate for community health and community health workers in addressing both direct and indirect health impacts of COVID-19 on communities. And I think that's really well reflected in comments from Peter Sands, our executive director, early on in the response, when he said that one of the top priorities in the response has to be protecting and strengthening community health workers. And this is really seen as a requirement if we're going to keep health systems funding, countries maintain the incredible progress that's been made in reducing morbidity and mortality from and incidence of HIV, malaria, and COVID. So from the beginning, infection control and protection of the health workforce has been a pillar of the Global Fund's response strategy, of course, in line with WHO technical and operational guidelines. So let me mention just a few things, specific things that Global Fund has done to support countries in protecting their health workforce, including community health workers. So when COVID hit, the first thing that Global Fund did was to quickly allow grant flexibility. So countries were able to reallocate portions of their existing grants towards procurement of PPE. And they also opened up their global procurement platform as one of the options, WAMBO, as folks will know, to help countries with active grants for quality products, including PPE. At the global level, within the Act A framework, and really with a mind to creating a more systemic approach to ensuring that communities and healthcare workers are protected, Global Fund and Welcome launched an initiative called Rethinking Ppe, which has brought together a coalition of partners to look at the full value chain with the country lens, from innovation, manufacturing, procurement, supply, deployment, utilization, and disposal. And then yesterday, as you mentioned, the Global Fund launched the second phase of the COVID-19 response mechanism, or C19RM. And this is presently at a level of about 3.7 billion in financing, which will provide opportunities for countries to support their COVID-19 control and containment interventions, including PPE, diagnostics, critical therapeutics like medical oxygen, as well as activities to mitigate effects of COVID on HIV, TB, and malaria services and support key health and community systems. So I wanted to talk a little bit more about the second phase of C19RM and really talk to the point of how do countries access it? What's it all about? So first of all, again, it's important to underscore that C19RM is limited to countries that are current recipients of Global Fund resources. Now, that good news is that that's about 120 countries in total, including some of the regional grants. So quite a wide global coverage. There are no specific programmatic earmarks. The funding requests will be developed by the country coordinating mechanisms, which are the central governing authorities, of course, in most countries. But they're going to be doing that in close collaboration with the national COVID response coordinators and coordinating bodies. And we'll focus on addressing gaps and priorities in the national COVID response plans. So we very much understand that countries need equipment, therapeutics, and supplies now. And so there's been some segmentation in terms of how these funding requests will be developed. There's a fast track that is heavily, which we're hoping will really accelerate and ensure that we can get these products out to the field, including to communities and community health workers as quickly as possible. And then there's a second or subsequent windows, which will allow for more comprehensive funding requests, where some of the health and community systems dimensions and mitigation aspects will likely be reflected. It's also important to mention that the funding requests do require that countries quantify their health workers, including community health workers, importantly, and define the needs of protective equipment. And this is a real opportunity for countries to build on the quantification work done through CAF-Africa and other partners to make sure that PPE and supply needs of the full health workforce are reflected in these C-19 funding requests and other related efforts. So let me stop there, Emily, and back to you.
Yeah, that's great. And I mean, 3.7 billion, that's, I hope that everybody listening, perked up their ears at the country level, really thinking about how countries can leverage that to meet these ongoing needs. And because it's a quick, turnaround, and we are in the midst still of the need for emergency response mechanisms, how do we build on some of these efforts very rapidly to make sure that the needs that are quantified are really representing that full health workforce. So thank you, David, and thanks to the Global Fund for their work in this area as well. I want to touch on local procurement because it's come up in the questions and the comments, and it's always something that comes up. Andrew mentioned we were able to do some local procurement under CAF-Africa this year in 2021. But I wonder, maybe Prashant, and I'll start with you, and if Chidima also wants to chime in on this in just a couple minutes that we have left. What is the state of the state for sort of manufacturing of PPE on the continent, and how much will that change sort of the market and how things look moving forward? Prashant, do you want to comment on that? Are you able to comment on that?
Yes, I think, Emily, it varies considerably depending upon the type of PPE. So for respirators, it is trickier because it requires specialized capital equipment, and we don't have very many manufacturers who have the kind of capital equipment that's needed for respirators, in particular the N95 and the KN95s. On the other side are products such as nitrile gloves, where the manufacturing is very concentrated in regions where the raw material comes from, and just the value chain costing doesn't necessarily create a lot of opportunity for manufacturing locally, not just in Africa, other parts of the world. I mean, everyone will have to face that concentration in the value chain of nitrile gloves. There are lots of things in the middle, surgical masks, aprons, gowns, where we are starting to see a lot more local manufacturers come up in Africa, some which were helped by global agencies, development finance institutions, some who did it on their own. But all of them continue to face the challenge that the demand side of the market for them is very fragmented. They don't know the channels of how to sell to the Global Fund. They don't know how to sell, in many cases, even to the African Supply Management Platform. So I think our challenge on local procurement will be, as new local manufacturers come up for especially these middle categories of PPE, how do we create for them a market connect platform that guarantees price, quality, delivery terms, those three variables that are extremely important, and put some more transparency on that and allows them to be a part of a larger sort of competitive procurement system structure.
Great, and I think that's a great segue to Chidima. Do you, how much are, how much are you all linking into sort of the local markets in Africa? How big of a component is that for you? And then also maybe if you can tie that into what's next for AMSP, sort of how are you looking at, your ongoing priorities as a platform as well?
Thanks, Emily. I mean, the local markets, the local distribution, local manufacturing, it's been a big topic internally for us because the opportunities are massive. We've also been part of, working groups and working sessions where we had to think through what were the possibilities and how do we finance, what role do we play in the future of locally manufactured products for the continent. And I believe that while the pandemic has offered us a good, opportunity to kind of really critique, and discuss what needs to be done to build the capacity that is needed. And when I say capacity, I don't mean just the infrastructure, but I also mean like the human capital, just, the regulatory frameworks and things like this. It's something that obviously work has already started on that. It's interesting to see with, for example, vaccines. And I know we're not talking vaccines here, but I mean, with vaccines, we know there's Aspen in South Africa that has a plant there. We know there's Institut Pasteur in Senegal. We know this in Egypt. They've already started talking, I think they've already signed with Sinopharm to, pack and fill the vials of vaccine in Egypt. So the conversations around local manufacturing, they have evolved massively. But to Prashant's point around, us being able to manage price, quality, and delivery, I think it's the same kind of 3 points we see when we have the conversations, right? We need to make sure that whatever we are producing, we're producing in such a way that we can manage the pricing and it's as competitive as what we get externally. We also need to manage the quality, and we need to talk a little bit wider around the regulatory systems that we have on the continent. And now it's really wide. I don't want you, it's really, if you produce a product in South Africa, you still need approval from the 54 different regulatory systems on the continent. So we're still talking and pushing around the African Medicines Agency being ratified to be able to ease some of the constraints we see around the regulatory frameworks for the continent. There's also the bigger question around the delivery timeline, and the African Free Continental Trade Agreement is supposed to be one lever, to bridge some of the constraints we see around intra-Africa delivery. So there's good progress happening, but there's just a lot of work that needs to be done. In the meantime, we have these conversations and we support as much as we can. And I think this is really important, as this is also part of our growth plan as a platform. MSP was also commissioned. One of our mandates is to also promote African suppliers and African products. But because we also did not have like the range, I mean, we are also really a buyer's platform, right? Buyers, we will stock what the buying entities want. And at the time, outside of PPE, is one of the biggest categories that we had requests for was diagnostic kits. We don't have any manufacturing structure that could offer that on the continent. So around pharmaceuticals, I mean, we keep having these conversations around where we want to see ourselves in the next 5 years, financed by local production. But I think what I'd like to leave us here around AMSP's plan is we are now expanding past the COVID catalogs and portfolio to addressing some other non-COVID related pharmaceutical needs. And that's where the platform as an organization is headed. Thank you.
Great. And I could talk to the three of you for a long time, but in the interest of time, I do have to turn it back over to my colleagues to close us out. So I want to say thank you to all of you. So much has been accomplished this year. The financing and technical platforms that all three of you have been involved in helping to set up are such a critical part of this response. So thank you. Now, we do know the work's not finished. We need to ensure that these channels and mechanisms are understood and are actually utilized and help to build the strong supply chains in country and globally and regionally that we need to meet community level demand. So thank you to all three of you. That's a role that all of us here on this webinar can help to play. And we look forward to working with you moving forward. So I am now going to turn it back over to my colleague and collaborator, Mila Nipanishi, who will just remind us all of the actions that we can take to make sure that we're protecting the community health workforce now and in the future. So Mila.
Thank you so much, Emily. Thank you, Krishna. Thank you to all our panelists for your contributions. I'm going to leave you with 3 key messages. Number one, make sure community health workers are counted. We can all do this now at the country levels, at the global levels. There's so many examples. Let's keep ourselves accountable. Number two, we know there are huge gaps between supply planning and community health efforts. Let's do our best to narrow that gap through integration at planning and execution levels. We can all do that too. And finally, we need multiple sources when it comes to procurement. We have to make sure that these are responsive, that these are transparent, they're agile, responding to local and regional needs, and they need to be in place for routine supply needs and also for future pandemics. To the many partners and over 200 donors who gave gifts of so many various sizes, thank you for your support to community health workers. Please stay in touch with us. Please share any questions you have with us. We will get back to you after the webinar, and we will also include the feedback in our final report, which we will disseminate in about a month's time. Thank you, and have a great rest of your day wherever you are.